Hello, everyone, and thank you for attending today's CFN webinar. Today's webinar is titled The eDosette Study, Optimizing Medication Use and Safety in Community Dwelling Seniors. The presenter and researcher today is Henry Hsu. Before I get into formally introducing Henry, I'd like to just welcome everyone and remind everyone that after Henry's presentation, there'll be a Q&A session. And you're able to submit questions online using the side tab, questions side tab there, as you can see on your screen. We'll try to get through as many questions as possible as time permits, but if there's certain questions that are not answered, please feel free to email Henry directly, and he'd be happy to answer any questions that you have. His email will be up at the end of his presentation. Just a few reminders that after the actual formal webinar ends, there will be a pop-up screen on your computer basically asking for some feedback. And this helps us improve our webinar series. So please, if you have a few minutes to spare, please fill out that survey. It really does help us improve the webinars. The webinar itself will be available as a video presentation on our website at cfn-nce.ca under News and Events, Webinars. And lastly, as a reminder, we have a couple of additional webinars scheduled for March 14th and April the 11th, so you're able to register now for those webinars if you're interested in doing so. So I'd like to formally introduce Henry Hsu. Henry is the assistant professor in the Department of Family Medicine at McMaster University. He's a director of Enhanced Skills Care of the Elderly program at McMaster. He studied medical genetics and microbiology at the University of Toronto, receiving his master's in 2004, and in 2008 he received or obtained his Doctor of Medicine. His research interests include complex patient management, care of the elderly, and developing clinical expertise in wound care. So with that formal introduction, Henry, I'm going to turn it over to you to begin your presentation.
Great, thanks, Perry. So I just started sharing the screen, so hopefully everyone can see the presentation. So again, Perry, thank you so much for that introduction. I think it cuts about 2 or 3 minutes off, so I don't have to introduce myself. But I'm really glad to have this opportunity to share about the work that myself and the other researchers at McMaster have been doing in this area, specifically around medication adherence and optimizing medication use in primary care. And so I want to spend the next 30 or 35 minutes or so talking about the results of our study, the eDosette study, and how this work is important for our older adult patients as well as for primary care. So with respect to disclosures, this study was funded by the 2015 Catalyst Grant through CFN. The pre-work or the feasibility study that I'll be talking about a little bit later in the presentation was funded by TVN, or the former name for CFN, as well as the Department of Family Medicine pilot funding. So I want to take some time just to quickly acknowledge my co-researchers and my project team. So David Chan, Michelle Howard, Dee Mangan, and David Price, all within the Department of Family Medicine at McMaster University, as well as our collaborator, Dr. Keen Fang, who's in the Department of Engineering Physics, and he has helped us with respect to some of the photo recognition software that was used in the feasibility study and in the pilot study itself. I do want to take this time to extend my gratitude and my appreciation to our research assistants, so Bethany, Jessica, and Fiona. Without the three of them and their tireless work with respect to contacting participants, troubleshooting with them, collecting information, reviewing MARs, uploading to participant charts and medical records, we wouldn't be able to finish this project. So I really am grateful and indebted to the three of them for the work that they've done on this project. So I want to spend a little bit of time first to talk about the background, and I don't want to assume that everyone here understands medication adherence or the the impact of medication adherence. So I do want to start from the beginning. And I mean, this topic, if you speak with any clinician, is not a new issue, and it's actually quite intuitive in terms of the impact of not adhering to your medications and negative health outcomes. In 2003, the WHO formally recognized this in one of their reports as a significant healthcare issue with respect to the impact of medication non-adherence on negative health outcomes. And if you look at systematic reviews in older adults, specifically in those with dementia, the range of non-adherence, unfortunately, is quite high. And although the studies themselves don't seem to agree on the exact rate, the ranges go anywhere from about 60 to 80%. So that's quite high in this proportion of older adults who are probably at the most risk for negative health outcomes. If we look specifically again at older adults and the risk factors for non-adherence, so things that are fairly intuitive to the clinician. So things like increasing medication regimen complexity. So how we ask our patients to take their medications, how the medications are dosed, the actions needed to actually dispense the medication. So a good example would be inhalers and puffers. How we ask our older adults to take them, and if we don't think about educating them and teaching them properly, could actually increase the complexity of their medication regimen, as well as polypharmacy. So not just the concept of the number of medications someone takes, but the appropriateness or the inappropriateness of that particular medication. Previous adverse drug events, impaired cognition, and then discordance between the patient and the physician around treatment decisions. So all of these are risk factors for non-adherence. And unfortunately, in the older adult, each of these are more highly prevalent. So as I alluded to earlier, medication adherence and polypharmacy both increase negative health outcomes, specifically things like falls, adverse drug reactions or events, hospitalization, and even mortality. But aside from that, a thing that we don't talk about as much, but is critically important in our healthcare system today, is just the idea of impact of non-adherence on healthcare costs. And in one very recent systematic review, a 2018 study, it looked at the cost of non-adherence in people with multimorbidity, ranging anywhere from $5,000 to about $50,000 per person per year. And so if you think about our older adult population in Canada, and as that population size increases, even $5,000 per person per year is a significant amount of cost to our healthcare system. In 2012, a study was done in Ontario looking at emergency visits, and avoidable drug events, or ADEs, led to about 70% of those emergency visits. Sorry, not 70%, 7,000 emergency visits. And of those ADEs, 70% of them probably were avoidable. And so if we think about the cost of that roughly in their study related to a cost of about $36 million. So again, a significant cost to our healthcare system from just visits to emerge alone in 1 year. So when you look at the background, and when the study team looked at their own personal practices and clinical practices, we identified both a knowledge and a communication gap. So specifically the knowledge gap, in primary care, primary care clinicians actually don't know how our older adult patients take their medications at home. And we have a lot of assumptions in how they use their medications based on certain things. So for example, if I were to receive a refill request on time, my automatic assumption, unfortunately, is that they've taken all of their medications as prescribed, as directed for that period of time. Another assumption would be, for example, if I don't hear anything about side effects, then probably none are happening. And both of these can lead to significant issues when thinking about how do you prescribe and how do you re-prescribe a particular medication. Related to that, obviously, is the communication gap. And a lot of older adults, fortunately, do not always talk to their primary care team, with their physician, their pharmacist, the nurse most involved with their care, about issues related to the medication. So why they're missing their medications, side effects that they might be experiencing, or even if they choose to start to cut down on medication for reasons like cost. This communication gap, as well as this knowledge gap, is a significant issue with medication optimization and medication safety in our older adults. So knowing that background, knowing those gaps, our team decided to think about a possible solution. And that's really start with the basis for the first feasibility project in this current pilot study as well. And our possible solution, as we proposed and as we lovingly named, was the eDosette. And the eDosette, what it is it's an actual device. It's a storage device for a person's blister pack or dosette that can electronically take pictures of that blister pack or dosette every half hour. These pictures are uploaded to an online secure portal, which can then be used to be converted into a medication administration record or MAR. And then this MAR is uploaded to an online personal health record that the patient has secure access to. So for those of you that work in acute care or even long-term care, the idea of MARs and tracking medication use isn't new. And this is something that's been done for safety reasons and as well as just for good documentation. But interestingly or unfortunately, in primary care, MARs don't exist in the community. And so our thought and our goal for the eDosette is if we were to be able to create a MAR for the community clinician, could that have an impact on medication safety, patient and adherence in our older adults? The other feature that the eDosette offers is something that we call the side effect alert feature. So this is a feature which allows the older adult to initiate contact with the primary care team if they feel that they're experiencing a side effect. And again, side effects can range anywhere from nausea, vomiting, constipation, diarrhea. It could be anything like that. We did take the time to educate our participants in the study not to press the side effect alert if there was a significant concern. So things like chest pain, stroke-like symptoms, anything that wasn't in a fairly short list, we did ask them to contact their primary care team by phone or to attend emerge or urgent care immediately, not to just wait for us to respond. When the side effect alert is generated, a message goes to the primary care team, and they usually they have 24 business hours to respond to ensure that there's safety as well as to triage what the issue is with particular medication. So this is a figure showing the evolution of our eDosette. So on the top left is kind of our first initial version, where again you can kind of see where our funding has come in, right, in terms of development of the prototype itself. So our first prototype was made with cardboard and file folders, and the picture that generated is just below that, versus the prototype that was used at the end of the feasibility study and going forward was much more sturdy and much more aesthetically pleasing. And the reason for that really was about picture quality. And if you look at the figures on the bottom from D to F, F shows much better picture quality than D. And so with pictures generated like with the quality in figure F, we were actually able to count specific pills. Unfortunately, we weren't able to identify specific what each pill was specifically because of just the size and lighting issues, but at least we were able to count how many pills were in each compartment. So I'm going to take a quick minute just to talk about our previous feasibility results, which really talks about the development of the eDosette before I jump into our pilot study. And so I'm quite proud of this feasibility study and the fact that we were able to get it published late in 2016, early 2017. And in that feasibility study, we worked with 10 older adults to see what the main issues were with the device itself and to provide some user testing around that. As kind of secondary outcomes, we were able to capture a range of adherence rates ranging from 65 to 100% with a median of about 8 medications. Our older adult participants were able to identify quite a few hardware and software issues that really helped us to refine our device and refine the prototype that we used for this particular study itself. When we asked our participants in this feasibility study about how usable and acceptable this device was, most of them found that the eDosette was easy to use. They basically stored their blister pack or their dosette in this device versus keeping it on their kitchen table or their kitchen counter. And they didn't feel that the eDosette would get them in trouble with the primary care team. And this is actually quite important for us to hear because we don't want to be punitive partners in this process. We don't want to be seen as we're tracking because we want to point out how someone is performing badly. We actually do want to be collaborative partners, where when we see something going wrong, we're trying to figure out what's going on, how do we troubleshoot, and how do we make it easier for the older adult participants to take their medications better. So in this current pilot study, our research question is looking at in community dwelling older adults with 5 or more medications. Can the eDosette reveal medication adherence patterns and impact medication complexity in the older adult over a 4-week period? So that was our main study question. And so the design that we used was a intervention cohort study in a group of 60 community dwelling older adults managing their own medication. We recruited this convenience sample from 4 different family practices in Hamilton and in Burlington. The eDosette prototype that was used was actually a subsequent iteration to the one I showed in the picture, but it was, again, a little bit better from the perspective of the data capture and the data transmission. And after the 4-week study, we followed up with a 3-month prospective chart review to look for kind of changes in terms of medication changes as well as health outcomes. So this is the intervention model itself, and it looks a little bit complicated, but I think it does reflect the fact that medication optimization work has to be complicated. It's not something that is a simple, take this medication as prescribed and everything will be fine. And so we start in the upper left corner, we have the older adult who stores their blister pack or dosette in the eDosette device itself. When the dose is taken, or when the older adult opens the lid, the device is triggered to take a picture. When the lid is closed, the device will take a picture every half hour regardless. All of these pictures are then transmitted to an online site where one of our research assistants goes through and converts them into a MAR. Our hope initially was to have software developed in order to do that, but we weren't able to get that done in the time frame of the study. So that is a hope that eventually, instead of having a physical person sit there and look at pictures, this could be done by software. Once the MARs are created, they're uploaded to the person's personal health records. So this is an online PHR, which can then securely be shared with anyone. So with clinicians, primary care clinicians, with their caregivers, with other people. And the primary care team then logs into their PHR, which is linked to the patient, and reviews these MARs on a weekly basis. If there's any issues that arise from these reviews, then a therapeutic conversation or a collaborative conversation is initiated with the older adult, and then any changes that are necessary are then communicated to their community pharmacy. If a side effect is experienced when a dose is taken, the older adult can generate a side effect alert. This alert then triggers a message that goes to the primary care team through the PHR in real time. And so once they get that alert, then they will respond within 24 business hours, again, to see what's going on, what happened. Do we need to bring this person in for an appointment, or can we troubleshoot over the phone? So when we look at our outcome measures, our main primary outcome measure was just the ability to calculate a medication adherence rate at 4 weeks. Our secondary measures, and the ones that I'm going to talk most about are the ones with the asterisk, is changes in medication complexity, regimen complexity, the frequency and type of medication changes, representing the optimization work done in primary care, and then the patient experience in the eDosette. The change in patient empowerment and frequency and type of side effect alert. I probably won't have time, but again, if anyone has questions, I can talk about those in the Q&A session. So if we look at our results, we were able to initially recruit 60, but of those, 3 ended up declining the study or left the study. So 2 declined after the initial phone contact. So when they found out about the study and they heard about it, they decided not to participate. 1 declined after the first home visit, where our RA went out to actually install the device and collect our baseline data tool. Our recruitment rate was about 25%. So overall, from the 4 different pilots, we had a potential pool of about 248 participants, and we were able to get 60 from that pool. The median number of medications in our participant group was 9. The average age was about 76, and if we looked at the number of daily doses that participants took, it was about 84% of them took at least 2 times a day, medications 2 times a day. The median for comorbidities based on chart review was 3. When we looked at frailty, we used the Edmonton Frail Scale to assess our participants. We did have a cluster of people that were in the apparently frail category, meaning that they scored probably anywhere between 6 and 11 on the Edmonton Frail Scale. It was about half and half. So the other half was scoring below 5, meaning that they weren't particularly frail. And this was unfortunately a nature of the convenience sample that we used for the study. For medication adherence, if you know the literature, there's lots of different ways to calculate this and to measure this. The way that we chose to calculate this was looking at 2 different ways someone could take medication, quote unquote, wrong in this study. So whether they missed a dose altogether or whether they were late in taking their dose. So our medication adherence was actually a composite outcome of both missed and late doses. And we were calculated individual adherence rates for missed dosing, late dosing, and then a total score at the end of the day. So from our overall adherence, we actually was able to get that huge range of non-adherence or adherence, depending on how you look at it, in our patient population. So adherence range anywhere from just under 50% to 100%. Not surprisingly, most people missed less doses than they took late doses. So if we look at our raw data, in our entire participant pool of 57 over the 4 weeks, together they missed about 500 doses of medications, whereas they were late about 2,000 times. So people took their medication doses much more variably within the day than missing a dose. All of these would have been reported to the pharmacist through the MAR, and follow-up would have happened to see whether that was a safe miss or something that was more concerning, that required more clinical conversation. So points to consider with how we're measuring this primary outcome. Obviously, because it's a convenience sample, we do have selection biases that we need to think about. As I mentioned, adherence issues was more around taking doses late, and sometimes that might not matter depending on the type of medication. So once a day dosed medication, whether you take it 2 hours after you normally take it or an hour before, may not matter at the end of the day from the perspective of the medication itself. And this was where we relied on our clinical expertise from the pharmacist to help us with determining that. The other thing to consider is this idea that intentional non-adherence might not be a bad thing. And the reason why I say that is intentional non-adherence may be a result of things like side effects, things like impact on daily life, system barriers like cost and things like that, that again, if we don't know and we don't talk to our older adults about that, we think they're non-adherent when in fact it actually is not an issue of non-adherence, but it's an issue of us not being collaborative and working with them to help develop a routine and a medication regimen that works for them and works with them. Other limitations, so we did have one participant, if you remember back to the slide a couple of slides ago, our range of medications went from 5 to 20. So our participant with 20 pills, unfortunately, we couldn't store all of them within the eDosette. We already tried to make the device as big as possible, and that was one of our feedback, that it was actually a little bit too big. But even then, we weren't able to store all the pills. Medications that were in the form of puffers or injectable medications or liquids or even PRM medications, we couldn't include into the eDosette. And that was just due to the nature of some of the storage instructions, as well as just the space and size. And lastly, there was an assumption on the research team and on the study team that if a compartment in a blister pack or the dosette was captured or taken, the picture was shown that it was empty, that we assume that all the pills within that compartment was taken. And we know that that's not always true. We know that some people will take all their meds, but they'll only take the ones that make them feel okay and discard the ones that either make them feel dizzy or not feel good, or maybe they don't particularly like this particular medication and they don't take it. So unfortunately, the camera doesn't capture that type of behavior around medication taking. We just assume that if all the medications are out of the compartment, and they've taken them all. So if we move into secondary outcomes, we look at medication regimen complexity. And for those of you who are familiar with this, we use the MRCI tool, so the Medication Regimen Complexity Index. So this is a validated tool looking at the number of medications as well as how they're dosed and the instructions for the participant. And it comes basically a score is generated for each participant based on their medication list and directions. From a clinical perspective, a change in 2 points has been deemed by other studies to be clinically significant, as that's equivalent to either one medication discontinuation or initiation. So the hypothesis from our study team was that we hope that the eDosette would reduce the regimen complexity at 4 weeks. And as you can see, from baseline to 4 weeks, we actually didn't have a change in complexity. If we went down to the individual level, the individuals had a change of 2 or more points had a reduction in MRCI scores by 2 or more points, meaning that we've at least discontinued or reduced their regimens by one medication. 3 participants had an increase in their score, meaning that we've added a medication itself. Even though it's not significant, the nature of this intervention study, as well as our participant size, it really wasn't designed or empowered to really answer this hypothesis properly. So when I talk about kind of next steps at the end, we do hope to do an actual powered RCT to be able to determine whether we can actually impact regimen complexity. The other thing that was quite interesting is to look at the frequency and type of medication changes over the 4-week study itself. And so chart reviews were done on each participant, looking at the number of medication changes that happened during those 4 weeks. So the median number of changes was 1 per each participant, but the range went from 0 to 7 different changes. And overall, if you look at all the changes from all the participants, there were 72 documented medication changes in the 4-week study in 31 of our 57 participants. So despite the fact that our MRCI scores in the previous slide didn't show a significance in terms of complexity, there's quite a bit of work being done behind the scenes around optimizing someone's medication regimen, as well as optimizing how someone takes the medication. If we were to look at the frequency of the different types of medication changes, the most common type would be discontinuation, followed by initiation. And you would think that that'd be kind of strange, like you're trying to develop a intervention that helps to reduce complexity, but you're finding initiation is the second most common thing that's being done. The reason, when you take a look further down into those 18 initiations, a lot of them were actually quite medically appropriate. So, for example, upon pharmacist review of their MARS and of their chart, we found in one participant, their A1C was completely out of control for the diabetes. And so metformin was initiated appropriately for that. And that was something that would have happened if we didn't have this study. Another person that was taking calcium but not vitamin D. So that was started by our pharmacist. So a lot of the initiations were very appropriate from the perspective of medical issues, as well as a lot of them were based on patient discussions around things like pain management. So people that had endorsed that they had more significant pain, recommendations were made around starting additional or different types of pain medications to help with that. Other work in terms of big categories is looking at dose adjustment or dose time change. And again, those wouldn't necessarily impact your MRCI scores, but they, again, reflect the fact that the work that's being done from the optimization perspective is more patient-centered. So it's asking the person, how do we make it easier for you to take the medication so that you can take them better? And that's reflected in those two categories. When we looked at the 3-month mark, I didn't include the chart in this one. We still had a similar amount of changes. There were less medication work done in the 3 months after the study has stopped, but there's probably a couple of reasons for that. Likely the fact that we weren't having these MARs to trigger the primary care team to connect with the patient on a weekly basis. So when we look at patient experience, we use the same survey we did in the feasibility study, and the survey asked participants 16 questions on a 5-point Likert scale, going from strongly disagree to strongly agree. When we coded it anything to the left of neutral, so strongly disagree or disagree was in the negative, and then agree and strongly agree were positive. So when you see a negative number, it means that the mean response in our 57 participants was that they disagreed with that particular statement. And again, we found that a statement like, "I worry that the eDosette may get me in trouble with my family doc when he or she finds out I don't take my medications as prescribed." We were glad to see that this was from a disagree to a strongly disagree. That again, the device was not seen as punitive, was not seen as a way for us to keep track of our just to make sure we're doing things right, but really as part of a collaborative model to help them live more independently and live safer. The other thing, again, as I mentioned earlier, in the feasibility study, people found the eDosette easy to use, and that also came out in our survey as well. As part of the survey, one difference that we did have in the survey versus the one in the feasibility study is we did ask our participants to write down the 3 best and worst aspects of the eDosette, starting to think about facilitators and barriers to the intervention model itself, because that's important for us as we think about kind of future studies and as we think about how do we integrate this into primary care. We need to understand the things that people do really like about it and really don't like about the intervention. So select positive comments, really focus on the the key aspects that, if you look at the literature today, should be part of interventions for medication adherence, namely communication between primary care teams, our clinicians and patients, reminders, and empowerment, patient empowerment. So looking at the fact that people are writing comments like they had a better connection with their pharmacist and their doctor, they're more aware of their health overall, that they actually noticed a change in their health is a great response. It made them more aware of their own medication schedule, how they take their medications. It was a good reminder. Even those, and even someone said that their friends and family had noticed a change in their behavior. So all of these are very positive, and they're very supportive of the fact that the intervention itself can help promote a positive behavior change that we hope will be sustained in the future. So those are the results, and I want to take probably the next 3 or 4 minutes just doing a little bit of discussion around the work that we did. And as I said at the beginning, medication optimization and this work around appropriate prescribing really should be centered within primary care. And the reason why I say that is the clinicians in primary care are the clinicians that work most with our older adults. They're the ones that will sit first for multiple issues, not just medications, but for other health issues. And this work of thinking about how do we help them take the medications better has to be focused in a setting where their whole context is being considered. And so I think that primary care does a very good job with that, and it helps with understanding. It helps when there's one person that's quarterbacking the entire care, so it's not individual silo specialists that are prescribing and may or may not be aware of the other medications. And it really does need to be done by someone that has their eye on the whole picture. The next point is this idea of 1 + 1 = 3, and the reason why I say that is there are different facets of interventions that work. So, for example, medication reminders work, Blister pack and dosettes work, having pharmacist reviews with patients work. But individually, their impact on medication adherence and optimization may not be as big as if we were to combine them together. And I think the study, or this pilot study, is showing a little bit of that, where the technology itself is a good reminder, but it's the connection piece that sometimes is missing from a purely technological intervention. And so when we remove the relationship between the primary care team and the participant or the older adult from the picture, we may not be getting as big of a change in behavior, medication adherence, by that, as we would see if we combine the two together. And so a lot of, again, as I mentioned earlier, a lot of the reviews and the literature is really pointing us towards thinking about grounding our interventions in behavioral theory, and thinking about incorporating different facets and making it really a multimodal and integrated intervention versus purely just a single intervention targeting a single aspect of that behavior. The next idea is talking about the idea of concordance versus strict adherence. So concordance is that next step after adherence. So adherence is when the person just takes the medication as prescribed. Concordance is when you start to have conversations around patient goals and preferences, and how that informs and makes the therapeutic relationship stronger, so that when you prescribe, you're prescribing not just appropriately, but also in accordance with the patient's wishes and goals. And so this idea of mutually agreed upon treatment is it's not a new idea. It's been out in the literature, but it's very difficult to measure, and it's very difficult to develop a strategy to improve that. And I hope that this intervention that we're proposing starts to take us into that direction, where we are starting to have an intervention that not only helps with knowledge gaps, but also helps with communication gaps. And lastly, as we saw in the results, the numbers unfortunately don't tell the whole story. So if you purely looked at the MRCI scores, if you purely looked at the adherence rate, you're probably not getting the whole story around the work that's being done around medication optimization and patient quality of life. So I want to take a minute just to talk about one participant story, so participant SFHC002. And this was unfortunately a sad example of where frailty and medication issues and multiple prescribers and poor communication and poor knowledge actually all intersect to provide or to lead to, unfortunately, a poor poorer outcome than if we had something in place. So this participant actually enrolled in the study fairly early on, and we recognized that this person was medically complex and had quite a few medications. And the clinical pharmacist and the MRP worked quite hard to align the medications with the person's goal and to specifically deprescribe some of the medications that were known to be have significant issues, specifically those tricyclics for neuropathic pain as well as benzodiazepines. And this participant finished the 4-week study, was doing fine, and unfortunately during the 3-month follow-up developed a delirium from a bladder infection and was then admitted to hospital. And while in hospital, the delirium got worse and she developed hallucinations. And that led to quite a few different specialists, so a geriatric specialist, a cardiologist, a urologist to look for other things. And in that mix, the primary care team was kind of left out, and we weren't as aware of what was happening. And so when this person came back out into the community and we were looking at the medications and we were trying to figure out why medications were restarted that were stopped, that led to more poor outcomes because we just didn't know. We didn't know what was going on. We didn't know how to make things better. And then unfortunately the MRP and the pharmacist was actually a little bit hesitant to stop medications that were started in hospital because there may have been very good reasons in hospital to start them, but again, without good handover and without that communication, we just don't know. So I think this particular participant is an example that this work needs to be done. It needs to be done on an ongoing basis. It's not a one-time intervention where you get assessed and then you're fine for the next 10 years. It is something that needs to be ongoing, and especially in our population of more frail older adults, this is something that needs to be done on an ongoing basis. So in summary, a medication administration technology, so like our eDosette that provides primary care with previously unknown information about medication adherence, could assist in medication optimization work in older adults. It can help us know how someone takes their medications and start conversations about why. Why is this happening, and how do we help make it better? Our next steps really include looking at a future trial now that we have this pilot study data. I'm actually preparing a grant right now for a CIHR to look at a formal RCT with the appropriate power to assess the intervention. We're also looking at this from a KT and a health economic perspective as well, recognizing that the intervention may be great on paper, but if it's not cost effective or helps with healthcare utilization, and it's not something that can be feasibly be implemented in the community, it's not something that's going to be of any help, and it will remain as a research intervention. And the team really hopes that we can move this into the real world and impact the safety and how older adults live in the community. So that ends my webinar. This is my email, so feel free, if you do have any questions that we don't get a chance to answer in the next 20 minutes or so, to send me an email. I'm happy to take the time to answer any of those questions.
Thanks, Henry. Great talk. A lot to chew on. We're waiting for questions to come in. So as we do that, maybe I could just start off with just a general question. First of all, quite an interesting insight in terms of intentional non-adherence. I didn't really appreciate that it would actually be a good thing to not be have intentional non-adherence, and it seems like it's a way for the primary care physician to sort of begin a conversation about the medications one is using, and then look to optimize the medications that one is being prescribed. So I thought that was a great insight and some excellent data there. I'm curious in terms of the process, and in terms of the process is quite labor intensive right now, as you indicated, because of the pilot study. And I'm curious how far along you are in terms of the software development, so that much of the back end work done by your research students and others could be automated.
Yeah, so that's a great question. So some of the things that we ran into during the feasibility and in the pilot study when we're trying to develop the software is it's really related to picture quality and the cost of getting good picture quality and the size of the device. So if we could have the kind of the perfect device as it stands right now, it would be much bigger than the one that we brought into the home. It would just allow better pictures, and it would allow for us to then be able to map each particular pill in each grid to image data from pharmacists and things like that. The other way that we're thinking about moving is instead of looking at individual pills to look at so again, for people that work in long-term care, you have those strips, and those strips have QR codes on them, which actually tell you which pills are in each particular pouch that's dispensed. And so that would be another way to think about that is if we were to change over the way that the medications are dispensed. So thinking about the device as not just a picture-taking device, but as an administration device, like that might be another way to think about that. And that's something that we're actually working with a local company in Guelph actually to see if we can make that happen for this future study.
Oh, that's great. Just curious, I know you've probably given this quite a bit of thought, but if I could, a follow-on question would be, once you've automated the system and you get alerts and so forth, how do you envision that working in terms of, do you envision that being sent to the patient as well as the family caregiver and others as well?
Yeah, so I think the important thing is, and that's why we're integrating the personal health record, because at the end of the day, this is the patient's health information, and they really do have the right to choose to share it with whomever they want. We hope that they share with the primary care team, but if we can get the technology there, what I would love to see is that not only are the primary care team kind of notified if there's anything that needs to be addressed, but yeah, caregivers are people that the participant actually wants to know about how they're taking their medications. For example, like if a dose is missed, an alert comes up on I don't know, someone's phone saying like, oh, your loved one missed a medication, like maybe you might want to check in on them or something like that, So I think that would be where we could go to, again, make it one step outside of, again, the research study and involve other people that we know are around this older adult, not just the primary care team, to help them with their medications.
Right. That's great. Just one last question from me. In terms of the ability of the patient to actually report adverse events, I'm curious from the physician standpoint, from your standpoint and your colleagues, whether they feel or may be a little apprehensive about having to deal with if let's say the eDosette was widely utilized across Canada, so the number of adverse event signals one might receive from his or her patients over time, and whether that might sort of overwhelm the primary care physician's ability to respond in a timely manner.
Yeah, you know what? So I didn't talk about this in this particular presentation. So when we looked at side effect alerts that were generated in our 4-week study, I know it's a short period of time, but we actually didn't get any side effects alert generated. And I think a lot of that is related to a couple things. I think one, sometimes the older adult doesn't know that what they're experiencing is a side effect. So they don't feel very good, or they feel a little bit nauseous. They chalk it up to, oh, maybe I'm getting sick, or maybe it's my disease that's causing this and not my medications. And so I think there's a little bit of a probably a knowledge gap that we need to fix there. The other thing too is we do have in our older adult population, especially the ones in the study, they actually some of them indicated they were hesitant to press the button because they didn't want to bother their team, and that's an attitude that is sometimes fairly prevalent in patient populations. And so I think there's a little bit of figuring out kind of where that happy medium is between telling the primary care team every time something goes wrong, or not telling them at all, and where is that medium? And that right now, because it's so unexplored, is something that I think we'll probably need to be focusing on in kind of future studies.
Mm-hmm. Yeah, that sounds like an important area in terms of educating the patient. We've got a few questions now that have come in. A number of people have indicated that they really appreciate your talk and the subject matter because it is quite timely. A very simple question in terms of the dosette itself. Who fills the pills within the dosette? Is it the pharmacist? Is it the patient? And how does that work?
Yep. So this device was created so that it would work with anyone's existing blister pack or dosette. So if it's a blister pack, it would be the community pharmacist who would have filled that blister pack and then delivered it to the patient. So the only thing this device is doing is it's providing a storage location for that blister pack. For the dosette, it would be the older adult who was doing it before. They would just continue loading their dosette. So this particular device doesn't necessarily help them load their blister pack or help load the dosette. It just helps us see how they're taking their medications when they've loaded their blister pack or dosette.
Okay, fair enough. Just a general question from actually a few different people about different competing technologies or ways of monitoring drug intake and adherence. I'm sure you've looked at other competing technologies. There's some that are mentioned by some of the people that have proposed questions, such as one from a company that has a blister pack that's tied to one's iPhone or smartphone, and every time you open the blister pack, it indicates that the blister pack was opened and presumably the medication was taken. So I'm not sure how in-depth you'd like to go at this point, but sort of the pros and cons of the eDosette versus other technologies that you're aware of?
Yeah, so that definitely was something that we had thought about initially, because yeah, there are actually there's quite a few very similar feasibility studies that looked at microchipping the back of the blister pack or even the caps of the pill bottle, so that we know every time someone opens their pill bottle. I think what sets the eDosette a little bit apart from those particular technologies is my point to 1 + 1 = 3. So the other aspect of the eDosette intervention is the fact that we're making this information now known to the primary care team. So whereas in some of the other technologies, like the data is there, it's just the connection to the clinician, to the primary care team is not being present. So I think, and not to shoot myself in the foot and say the eDosette isn't necessary, but we could substitute out that technology for another technology that does the same thing, right? So I think the technology itself, I don't think matters as much as the data that it captures, and then the ability to then share it with primary care and not just with a particular person or a caregiver, and then to see how that actually impacts how someone takes their medication. So I hope that answered the question, because I know that there are definitely lots of different things out there. The other thing that sets eDosette a little bit apart is that we're not asking the participant to change the packaging that they're using. So we're not asking them to use new blister packs or have to kind of deal with the cost of having microchipped blister packs or cap bottles. They can use whatever they have right now at home, and they can just put into the particular unit itself. So that would be another thing that it separates it a little bit from some of the other technologies out there.
Right, that's a good point. And something that I actually flagged in your last slide about a follow-on study and looking at cost effectiveness and so forth. And I have a couple of questions related to that in terms of, and I'm not sure if you've taken a look at this because it's fairly early, but whether you looked at whether the final version that you eventually envision being given to patients, at what cost would that be in terms of retail costs, if you will, or cost to the family physician and so forth?
Yeah, you know what, that I actually can't speak to well, partly because I think we're still creating the ones that we use for this study in someone's basement. So I think our production line is going to be quite we need to think about that. I think what our hope is we want to make it accessible so that people can use it without cost being a barrier. I think that really is a goal, and I think in order to make that happen, like, we need to have the data to support that it's effective. So if the intervention is effective, we can then go to policymakers and public payers to say, this is something that can help you decide which medications to fund on your formularies, because we can show that people are taking medications well and things like that. So we may need to work with partnerships outside of just having the participant or whoever wants the device in their home to pay for it. The other area that I do foresee where these type of devices might be very helpful would be in that older adult population that is not completely independent, living in the community, but not needing enough assistance to be in long-term care. So that transition period, so I mean, those typically can reside in retirement homes, or they live with their children or other loved ones. Those people might be the ones that would benefit most from something like this. And there may be a way to think about, maybe maybe instead of having this type of device in the home 24/7, it might be something that is given to someone for a month at a time or 2 months at a time to see how things are going, and then changes can be made. The device can be taken out, given to someone else, and then brought back a couple months later to see how things are going. So there's lots of different strategies to think about how to make it accessible for different residents. But I haven't thought too much around what the price point would be for participants.
Yeah, no, fair enough, and that's probably somewhat of an unfair question from me at this point, but I thought I'd ask anyways.
Yeah.
Just sort of related to that, I'm looking at the eDosette, and in many ways, it is a camera or scanner sort of device. And I was wondering, have you ever given any thought to, because of the camera technology and the software technology with machine learning now, for many of these smartphones like iPhones and so forth, are able to do quite complex facial recognition and so forth.
Yep.
Have you looked at whether that's a possibility of using the cell phone to do the image capture and then the back end being the same as you do right now?
Yeah, that's a great question. I think cost was probably the main prohibiting factor for the camera that we were the hardware that we were able to use in this particular device. I think you're right. I think a lot of algorithms that like iPhones or Android phones are using to in their camera technology. I think that would be great to incorporate into something like this. I think that would really help with identifying specific pills and to be able to say like, oh, this, and not just 2 pills were missed today. You can actually say like which of those 2 pills, and to link that to, again, information around how pills look and things like that. But and that's something that I think Kian, who's our collaborator at the Department of Engineering Physics, would I'd probably talk to if we get this larger grant to see what we can do about that.
Yeah, that would be neat. It would go address somewhat, anyways, the cost effectiveness of developing.
Absolutely. Yep.
I've got a question here, and I'll just read it verbatim. The opioid family of medications and accidental poisonings leading to ED visits has been highlighted by Kai-Hai. Did you look at this issue specifically, perhaps even informally, in your study?
So interestingly, I'm just trying to think, because I don't have the raw data right in front of me. We did have participants that were on opiates, and we did, I know, in certain participants start opiates actually because of pain-related concerns. One of the visions of David Chan, when one of the co-investigators right at the beginning, was his thought was, could we use this to help monitor appropriate opiate usage in the community? So we would be able to tell, like, how someone's using their opiates. Like, is their request for refill appropriate, or is it early for whatever reason? So we didn't specifically look at the opiates themselves, but that is something that we were thinking, like, as another application of this technology, is looking at opiate monitoring.
Oh, that's great. We're coming now to the top of the hour, so I think we'll finish off the questions at this point. I want to give you sort of a last opportunity to give us any final thoughts or comments you'd like to make prior to us closing the webinar.
So again, I do thank CFN for the opportunity to actually run this study. I think this is an area that's really interesting for myself. I think I personally work in long-term care, as well as with people that are older in my practice, and it's always an issue, and I'm much more keenly aware of it now. And I think just being part of the study has impacted how I run my own practice and how I think about medications in my particular patient. So I do see a value in the work that's being done by myself, but also for other people that are in the same vein, in the same field. So I think I probably would end off by just saying that, medication optimization work in primary care is important, and it's something that we in primary care should champion. And I know a lot of work is being done by people in primary care, community pharmacist colleagues, and things like that. So I would say that that's something that we need to continue thinking about. But other than that, like, I hope I get the grant, and hopefully we'll be able to tell all of you more about that as we progress.
Okay, well, great. I hope you get the grant as well. I want to thank you again, Henry, for for taking the time to give your talk today, and want to thank the audience for attending today. Again, if anyone has any specific questions for Henry, please email them at the email address that's indicated on your screen right now. And please, after the webinar, please fill out the survey if you do have the time. And again, thanks, Henry, and thanks, everyone. And we're going to close out this session now. Bye-bye.